a consultant neurologist here in Nottingham. I'm an academic neurologist, and my expertise in the field is working with the MS register and Richard Nikos from Imperial. I have tried to understand a bit more about how COVID affects people with multiple sclerosis. I'll introduce also Afagh.
Hello, I'm Afagh. I'm a clinical research fellow with background of neurology. Have been working with Nikos since the start of my PhD, and currently I'm also working with the UK MS register on COVID and MS.
Thank you, Afagh. And then we have Terri.
Hi, my name is Terri. I am the lead MS nurse here in Nottingham. I'm quite new to the post, but I work alongside Dr. Evangelou and the rest of the team here in Nottingham.
And thank you, Terri. And we also have Christopher.
So I'm Chris. I'm one of the other clinical research fellows. And while my research covers MS, it's not specifically COVID related. So I'm here to learn about what the rest of the team has been getting up to in the last couple of months.
So the purpose of this webinar is really to exchange views and ideas. And the presentations, I will introduce some of the data that has been presented recently at ACTRIMS. Then Afagh will present some of the data that we have collected here in the UK with the contribution of all of us, all the neurologists and the nurses and the therapists and the pharmacists that contributed the data to the UK MS registry on COVID. And then we're going to have a bit of a conversation, hopefully triggered by some of the questions that will be asked by you and some of the internal arguments and discussions that we have here in Nottingham. Things are not black and white. We know that in life and even in the management of COVID. So we have spent 6 months of dealing with COVID in the field of multiple sclerosis, mainly and understandably trying to extrapolate from the evidence we have on disease-modifying therapies and viral infections, but without really having any robust evidence of the disease. And we have been lucky in MS that a number of centers, a number of initiatives in the UK, globally, in Europe and in America and in South America, has started collecting data. So 6 months later, 9 months later, we are a bit more equipped because we're not only talking about speculations, but we have some data to discuss. And this is what we're going to do. So I introduce the members of the team. I thank the MS Academy for arranging this webinar. It has been, without the support, we will not be able to do lots of educational initiatives in the UK on multiple sclerosis. I'd like to thank, obviously, the MS Register, because lots of the work that has been done in the UK, we have used the MS Register as the center point to build the knowledge. And of course, I have to thank my employees, the Nottingham University Hospital and the University of Nottingham. So conflicts of interest, I have been funded to do research by a number of bodies, and I have participated in some advisory boards. And because I mentioned that there are a number of publications and presentations from different parts of the world, I cannot mention all of them. But I just picked up, and this is from Barcelona. So it has been presented before and has been presented also at the ACTRIMS meeting. Barcelona is very well known of having a longitudinal study of people with clinically isolated syndrome. Is a very big unit and very much respected. So what they have done, they have said, okay, we have this infection, we have people that are coming to a clinic, let's send a survey to them by email, and let's find out whether our patients have been affected by COVID. And you can see the structure of their work. They have sent almost 3,000 invites. Out of those, we have 758 people with multiple sclerosis responded, and you could see that 48 people have said that I have had COVID. Then in addition to that, in addition to the people that they have responded, they have also added the number of people that they knew from their service that they have been affected by COVID, and they had 93 cases of COVID. So during the summer, they calculated that 6% roughly of their patients with MS have had COVID. And then they tried to find out what increases the risk of getting COVID. And you can see there are relatively few things in the MS population that has increased the risk. Surprise, surprise, if you are cohabiting with somebody who has symptoms of COVID, it increases the risk. If you have been in contact with somebody who had positive PCR for COVID, it increases the risk. Wide confidence intervals, but if you have a liver disease, it seems to be increasing the risk. But everything else is more or less somewhere in the middle. So you can see, whether you are a smoker or not a smoker, there is, if you have any other comorbidities, probably increase the risk, but there is nothing striking. And even if we go to medicines, there is a bit of a flavor that if you were on disease-modifying therapies might increase the risk compared to if you were not. But again, the confidence intervals goes to 0, so there is nothing striking. You can see the most statistically significant, if you believe in p-values, but you can see, of course, the effect size is probably more important, is that, yes, if you are on disease-modifying therapy for more than a couple of years, it just tiny increase the risk of COVID. They did a couple of other analyses that I'm not going to show, and this is their conclusion, that compared to the rest of the population, the incidence of COVID in MS patients was not higher. Surprise, surprise, if you are in contact with somebody who has COVID, you have a risk of getting the disease. There has been a bit of a discussion about the anti-CD20 rituximab and ocrelizumab treatment, and considering that they have done lots of comparisons, they found a bit of a signal that if you were treated for a long period of time and if you were treated with, it might slightly increase the risk of the infection. And if you are old, and of course we knew that from all the studies that has happened, across the world, if you are old and you have comorbidities, you tend to have a more severe disease. There has been a bit of a discussion about, the evidence is very, very weak, and the evidence that they presented was very, very weak. We know that the antibody response might be significant if we ever get a vaccination for COVID, and they wonder whether with their evidence, whether there is a vaccination response in people that they were taking anti-CD20 treatment is the same as the ones that they were not. The line of evidence presented by lots of the centers is very, very similar. So I was very, very excited to see some of the presentations of 11,000 people in Brazil with multiple sclerosis. And I thought, wow, this is a comprehensive survey. But at the end, out of these 11,000 people, so the Brazilian team has reported the 94 people that they had with COVID, and out of those, 32 were confirmed with PCR. And they have found what the Spanish and the Catalonians have found that the majority were mild. There were only 2 patients that developed sepsis, and at that stage, only 1 patient had died from COVID. In terms of other information from Brazil, that the majority, there were more people that were not on any treatment. There were, you can see, some different percentages. All the medications have been presented, and the majority of people that they had the infection, they did not have any comorbidity. And the final interesting information that I found from the ECTRIMS meeting is this poster from Austria. And what they wanted to see in the hospitals and outside of hospital, there are all these risk factors stratified, and you can calculate how much at risk you are from getting COVID and you getting a bad COVID. So they said, oh, we're discussing quite a lot about our disease-modifying therapies. Let's see if these DMTs that we're using can be complicated by the high risk factors that some of our patients are having, and how we're going to manage it. So there are a number of mortality risk scores. This is the one that they're using in Austria. Whether you have diabetes, your old age, chronic kidney disease, whether you have physical disabilities, and depending on the total scores, you can get a high risk for a serious COVID infection or a low risk for a serious COVID infection. And they have found let's concentrate here on the whole cohort, they have found that out of their population is really 26%, of them were smoking, which is probably a higher number than I would have expected from Austrians, that they have multiple sclerosis, and we know smoking is bad for you. There is a 12% chance of being obese and smaller percentages of other chronic illnesses. This is, I think, the most interesting, is that the vast majority, the 63%, they had a very low risk of bad COVID. And if you add it with the 26% that they have a mild risk of bad COVID, so the majority of people that are on their books with MS, they do not have a high risk of COVID. And there are only 3 people out of more than almost 2,000 people that they have very high risk of COVID. And of course, none of them were taking disease-modifying therapies. So we concentrated too much about the disease-modifying therapy, but what the Austrians are suggesting, that they are really people that they have a very high risk of COVID. Usually they are not on DMTs. And with this, I'll stop here, and I will try to unshare my screen if I can do it. And I will ask Afagh to, so the problem that most of the studies that have been presented in ECTRIMS, they were selective. There was a group saying that here it is, 20 people or 40 people or 100 people have been affected by COVID. And it has been a positive message that people are not, by and large, being affected as much as we have feared. Afagh, do you have any other better evidence to show us?
Yeah, we'll see. Thank you, Nikos. So, as Nikos pointed out, I'm going to present the findings of our study in the UK on COVID-19 and MS. So obviously I'm presenting this on behalf of the study team, which has been a national effort and consists of experts from all over the UK and the UK MS register team. My disclosures, and First, I'm going to quickly go through the outline of our study to make you familiar with what we're doing. This is an ongoing study. So the UK MS Register has been collecting prospective and longitudinal data on people with MS about different aspects of their MS, their mental health since 2011. And when the outbreak started in the UK on 17th of March, a week before national lockdown was implemented, we launched a study, and here I'm going to present our findings until 5th of October. So our study has two arms. One is a community-based study where people with MS report on their COVID and different aspects of that. And the other one is a clinician-based study where clinicians, other healthcare professionals report COVID-19 cases in people with MS. And today I'm going to mainly focus on the community-based arm. So when we launched this study, almost 18,000 people with MS were registered with the UK MS Register. Out of those, about 3,500 had been actively providing data in the 6 months prior to the pandemic. And after we launched the study, another 2,400 people joined the register. And so far, well, until 5th of October, we got 6,600 people participating in our study, which is very impressive. And more than 2/3 of those continue to provide data in our follow-up surveys. So out of the 6,618 participants, 709 reported that they thought they had COVID at some point, which gives us a prevalence of 10.7%. And 41 out of those had also confirmed their diagnosis by testing. And the fact that we can actually know the prevalence of COVID in our population is unique to this study, because we had a cohort of people with MS that had been providing data from before, and now we keep asking them, do you think you have COVID? And we just ask other questions as well, which I'm going to present.
Afagh, because you are, you would like a bit of interaction, and everybody likes a bit of interaction. So how does this compare with others? So what about the you have read about the Italians? They have also reported some percentages.
So most registers, which have been mainly set up after the outbreak, are similar to the clinician-based study that we're running. So they report on people with MS who have been diagnosed with COVID. So they're able to assess the severity of disease, the outcome of the disease. But as I said, this is the fact that we can assess the risk of contracting COVID-19, or see in general how people with MS are doing during the pandemic, is because we have access to all these people with MS via the platform of the UK MS Register, who have been providing data, and they don't necessarily have COVID-19. So we're able to, in real time, detect those who develop symptoms and find out what's happening within the population in the UK.
Fantastic. I simply wanted to raise the point that you are very, very, happy to receive questions in the questions and answer section, and we'll try to interrupt you and make it as interactive as possible.
Of course, of course.
Terri, the next time you want to ask something, feel free to interrupt Afagh.
I will, thank you.
So this is chart just to give you an idea of what's been going on since we launched the study. So first, I'm going to describe the red line with the circles as the data points. So this is the rate of reporting self-diagnosed COVID-19 in our study population. So as you can see, 4 weeks after the study was launched, 5.5% of people who had participated in the study at that in that interval reported a self-diagnosis of COVID-19, and that started to reduce until shortly after the lockdown. And as we can see, there are some signals that's increasing again, similar to what we see in the general population. And just because this is a self-diagnosis of COVID-19, and some people may criticize that, we just wanted to check the validity of that through using different definitions of COVID-19. So the yellow line here shows the rate of reporting lab-confirmed COVID-19. And obviously, recently we've had more testing, but again, especially in the second half, you can see a similar trend to self-diagnosed COVID-19. The blue line indicates cases that had been diagnosed based on the WHO criteria, and that is if you have fever plus at least one respiratory symptom, and the green line indicates cases diagnosed based on the prediction model proposed by Many et al. In their paper, and they use different symptoms of COVID, like loss of taste or smell, fatigue, respiratory symptoms, and gave each symptom different ways to predict how likely it is that someone would have a positive taste based on those symptoms. And as you can see, the trends with those two diagnoses are similar to self-diagnosed COVID as well. So then we also wanted to see who is more likely to self-isolate in our study population, to both know the behavior of people with MS and to also help us interpret our other findings. So until 5th of October, 50% of our study population, that's more than 3,000 people, reported that they had been self-isolating at some point. And when we did a regression analysis, multivariable regression analysis, I tried to keep it as simple as possible. And as you can see, so an odds ratio of more than 1 indicates a higher likelihood of self-isolating. So those with older age, those with a higher EDSS score, those with the higher score on the physical component of the MSIS score, and those who were taking DMTs in general were more likely to self-isolate during this time, and a higher EDSS score was the strongest predictor of self-isolation in the study population. But then again, we looked at individual DMTs, and it seems that those who are on monoclonal antibodies on cladribine or fingolimod are more likely to self-isolate compared to those patients who are on self-injectables or again, in a separate analysis compared to those who are not taking any DMTs.
So, Afagh, just to, if you go back to your previous slide, so the people that they're taking alemtuzumab and cladribine, they're isolating more. So, are you going to take this into account on the infection rates?
Yes, so because some groups are self-isolating more, when we want to assess the risk of contracting disease, we need to adjust for that factor. So in the analysis that I'll present, we have taken self-isolation as a confounding factor, because if you self-isolate, obviously you have a lower risk of contracting disease. And when we assess the risk of contracting disease in relation to individual DMTs, we take that into account.
That's a thorough way of looking at it. Thank you.
Okay. So just the same point. So now we want to see who is more likely, so within our MS population, who is more likely to contract the disease. And here's again a chart with an odds ratio of more than 1, indicating a higher likelihood of reporting self-diagnosed COVID-19. And as Nikos pointed out, and I explained, we adjusted for different factors in the analysis, including self-isolation. And it seems that people with older age have a slightly decreased risk of contracting COVID-19. Those with higher EDSS also have a decreased risk of contracting COVID-19, which we think might be because of other confounding factors, except for self-isolation. Maybe these people are being generally more cautious. There is a very slight signal that the confidence interval is not as narrow as age or EDSS, but females seem to be reporting self-diagnosed COVID-19 more than males in our population. This is interesting regarding ethnicity, because in our population, people with MS from ethnic minorities were more likely to contract COVID-19 compared to those from a white background. Because MS is generally more common in those of white ethnicity, we didn't have enough numbers on each group of ethnic minorities to assess the risk separately, but this increased risk is similar to what has been found in the general population. So some of the other MS-related factors, we can see that taking DMTs again associated with a lower risk of contracting COVID-19, but is close to 1, and it wasn't significantly, it wasn't statistically significant. So what we can conclude, and what's the point of all this analysis, is that taking DMTs and physical disability at least do not increase the chance of contracting COVID-19 in people with MS. And then again, we looked at individual DMTs, and the same thing goes, and again, adjusted for self-isolation, and none of the DMTs individually were associated with the risk of contracting COVID-19. The chart here uses a self-diagnosis of COVID as the outcome, but we repeated the analysis with the other definitions, like lab confirmed, WHO diagnosed, the prediction model, and essentially we didn't see any signal that any individual DMT would increase the risk of contracting COVID-19, no matter if we compare them to self-injectables or we compare them to taking no DMTs. So the next point would be discussing recovery from COVID-19, with all the discussions around long COVID in the general population and the consequences of COVID infection. in the general population. It's obvious that we would be concerned that what happens to those people with MS who already have some degrees of physical disability when they contract COVID-19. And the UK MS Register gave us a chance to follow these patients up. So 700 people reported a self-diagnosis of COVID, and almost 400 of them have continued responding to our follow-up questionnaires. And so far, 76% have reported full recovery from COVID-19. And the median duration of their disease was 10 days with an interquartile range of 6 to 21 days. And 24% haven't reported complete recovery yet. And we have so far followed them up for a median duration of 105 days. So again, within
25% is it a big number?
So it's not. So it's very impressive that 76% of those who responded have said that they have fully recovered.
Like you're either half full or half empty.
I'm looking at the half full, but yeah, I'm not going to comment on the 24% because there are another 300 people who haven't responded yet. So I'm looking at the 76%, and it wasn't long.
Chris, any comments on this, the 24%? You're a well-read individual.
I think we were discussing before the webinar began about the BMJ's survey this week showed, I think, a very similar percentage of doctors reporting long COVID sufficient to interfere with their work. So we'll wait and see, as Afagh says, the data. We're still awaiting the follow-up data, but it wouldn't surprise me if we were a lot closer to the final figure than we thought. We'd expected long COVID to be a much smaller percentage, perhaps, but there's depending on the definition used, we could be looking at a group as large as 1/4.
But this is spectacular. Not only the 25%. I think that if we look at that, in a quarter of our patients, and of course a quarter of patients outside of the MS, population, would imagine that there will be people that the whole thing will carry on more than 3 months. So it's not the quick I get a bad cold for a week and we'll be fine. It's much longer than that. So with major implications, as we keep hearing every day, on how do we rehabilitate people with MS on COVID, and how do we rehabilitate long COVID. I wonder who are the people that they're taking longer to recover.
Exactly. So thank you. That is the second point. So we looked at factors associated with recovery, reporting full recovery from COVID-19. And here, an odds ratio of more than 1 reports a higher likelihood of recovery. So if you have an odds ratio of less than 1, you're less likely to report that you have recovered. And well, probably not unexpected, we found that those with a higher EDSS score were less likely to report full recovery. And this is the bit that interests me. Those who had anxiety before the outbreak, and this is because the UK MS Register had been collecting HATS scores since 2011. So those who had anxiety were less likely to report full recovery from COVID-19. And this is for the duration of our follow-up, which has a median of 42 days. So essentially, this means that if you have more physical disability or if you have anxiety, you're less likely to less likely to have early full recovery from the disease. So then again about recovery, one other concern among people with MS and healthcare professionals who take care of them is whether the effect of the pandemic on MS symptoms. And we ask people with MS if they have experienced any changes in their MS symptoms during the pandemic compared to before the outbreak. And 53.5% reported no change. 41.5% reported that their symptoms had become worse, and 5.1% reported that their symptoms had become better. So then we took so we wanted to see who were the people that were having worse symptoms compared to no change during the pandemic. So again, we did a regression analysis. So if they had a higher EDSS score, they were more likely to report worsening of their MS symptoms. If they had secondary progressive MS compared to relapsing remitting MS, and I haven't added it here, but so we didn't find the effect compared to primary progressive MS, but secondary progressive MS compared to relapsing remitting MS, they were slightly more likely to report worse MS symptoms. This might be due to the nature of the disease rather than the pandemic. And those with anxiety and or depression, either before or during the outbreak, had a very higher chance of reporting worse MS symptoms. And those who had COVID also were more likely to experience worse MS symptoms. But if you take the whole chart, what is interesting to me, I guess it has been interesting to the whole team, is that the effect of anxiety and depression on MS symptoms is strikingly high. So almost 4 times, if you have anxiety or depression, you're 4 times more likely to experience worse MS symptoms. But if you've had COVID-19, you're almost 2 times more likely to experience MS symptoms. And that emphasizes the effect of mental health and the importance of mental health among people with MS. So I think that's all. And here's a summary of what I've presented. I won't go through it, just keep it.
I think that was an exceptionally well and thorough presentation. Thanks to the data and of predominantly the people with MS that have given the data, have filled in all the questionnaires, and of course all the healthcare professionals that they have given us the data on the people that they have had COVID. So the UK MS registered study that was essentially a population study. Can we call it a population study? It's a population that we study, shows that the DMT do not seem to be playing a significant role. Then you came along with this very provocative statement that mental health plays an important role.
Surprise.
Surprise, surprise. And who knows what will happen now in the second wave. So the question, until the questions come along. So Terri, what do you think about this mental health aspect, and are we looking after our patients well?
I think certainly we are having an increased call, certainly during this second wave that's coming about and apparent, certainly in Nottingham. We're having a lot of calls about home, their mental health, and we're being a bit of a source of support and giving them that psychological support. We obviously are referring on to external agencies of counselling, getting people to sort of approach that idea, but certainly our team are giving a lot of support to patients and how finding solutions and sort of ideas really. But certainly I think, you know, now we know this morning in the news, Nottingham, you know, potentially looking at tier 3, and that's going to fuel a lot more anxiety, and for those especially that live by themselves as well, and how that's going to look for them.
So I know that you're getting lots of calls, and so what is the most common, you know, for you know, how many calls do you get a day?
How many calls? So roughly, we've been keeping a bit of a log each month actually. So I think in September last month, I think we roughly had about over 420 calls a month. That was purely nursing calls. That wasn't all due to COVID, obviously, but that's a volume of calls. And again, something reflecting on what Afagh's just presented, there is a lot of anxiety that obviously is impending, and I want to ask us a lot about the DMTs and people's work, and if they can't work from home, and accessing all different services. That's hugely having an impact on sort of people. But there's a variety of questions they're asking, and is trying to, I think certainly something over the last week especially, is not able to access GP surgeries or even speak to someone, so they then want to speak to us, which is absolutely fine. But I think they prefer speaking to us sometimes. We might have more of a solutions.
But it's a big workload, you know, considering that we are struggling now with the second wave, and these are the calls you are implying that we get not change my appointment. This is dealt by the admin team. So this is, I would like to speak to a health professional, because 400 in a month is exceptional.
Yeah, absolutely. And I think certainly in August you could see there was a bit of a shift. I think obviously during September, I think that's when the news and the media was fueled about, potential second wave and getting ready for that in the NHS. Our numbers weren't that big in August of our calls. I think there's probably maybe 250. So we can certainly see the increase in nursing calls that we're receiving about COVID and other things.
Chris is looking at the question from Guy. Who
I was about to say, can I jump in now?
You jump in. I bet this is an open conversation.
So I suppose to either you or Afagh. So Guy's laid out. So it could also be that people with anxiety and depression are generally more likely to report worsening physical health.
Exactly. So. Very good question. So that's another thing that we looked at in our data. I didn't present, but again, those who had anxiety or depression were more likely to report a worsening in their general health as well. And I think this is all about how people with MS are feeling themselves. It is a subjective feeling of general well-being, no matter if it's general health or MS symptoms. It shows that if you have anxiety or depression, that affects your general well-being.
Okay. So pending our live audience submitting some more questions, I thought I'd submit some that I prepared earlier from some of our other MS nurses who couldn't join us on the call. So what about the people who are really concerned about returning to work, especially now that there's a lack of shielding? Do you think that there's enough evidence building in your data and that in terms of ACTRIMS and ECTRIMS to perhaps reassure these people? I suppose that goes to any of the other three.
I mean, the only evidence that I can say is that, roughly speaking, and when I say roughly speaking, I don't know if we'll do the calculations at the end of 2021 and we find that people with MS on treatment, they might have a slightly increased risk. But roughly speaking, people with multiple sclerosis, they have the same rate of infections as people that do not have MS. And roughly speaking, they do not appear to be more affected in terms of outcomes. So I think my interpretation, until we continue to collect data, and we need to continue to collect data, we need to see the people that participate already from the MS register to continue to tell us how things are going. Until then, we're doing more harm by, preventing people to go to work or keeping them at home or continuing this fear that, you will go outside to the supermarket and you will catch a terrible illness. It's a terrible illness. There's no doubt that to the people that have been affected and they have died, we know we have 40,000 deaths, so it's not a problem. But I think, the evidence suggests here that people with MS are not really much different from the general population. Most of the people that they will do badly if they have COVID, most of them, they will have other, they will be of old age and they will have other comorbidities.
So I think that message is probably most aimed at the newly diagnosed population. Is that fair to say that these are the people who are coping with the psychological distress of a diagnosis of a chronic neurological condition, and not only that, they are suddenly confronted with COVID and a lot of people talking about MS and COVID at the same time. So do you think we should be aiming that message at our newly diagnosed population?
Terri, what do you think? I mean, the way I will take it, having been thrown the diagnosis of multiple sclerosis at a young age, it's a major blow. I think I would have gone to pieces. And then after a while, there is the chaos behind us and the fear, and you see every day how many more people have died, and you hear vulnerable individuals. It's understandable. But if you go and look at the objective evidence, the rates of infection, the rates of deaths, most of the newly diagnosed people with multiple sclerosis, they will have a significantly lower chances of a bad infection or death than I have, because I'm a bit older than the average people diagnosed with MS.
And I think certainly maybe those that have been newly diagnosed as the second wave's approaching, I think we've got the evidence from the first wave, and I think we can really demonstrate that to them. So when we're offering, especially people with a new diagnosis, we can offer DMTs if appropriate, that we always do have those discussions about how COVID fits in that. And that's something I think patients are really wanting to ask us, and I think we can actually show the evidence, what we've learned from the first wave and how we incorporate that. But that's definitely a discussion we do have, especially at new diagnosis, as we form a working relationship with our patients.
Okay. So last question from me. Well, maybe
Chris,
not
I will ask you that. I will ask you, because you're a neurologist that see lots of people. They come along to the study and they deliver MS, and they say that I'm newly diagnosed, I have had my relapses, I think I'll better wait until the pandemic settles down before I start any treatment.
Yeah,
Christopher Allen, your answer.
Yeah, so I think what we've stressed is we know the morbidity of MS. We are generally moving towards a treat early mantra, but we can't let this webinar end without a plug for Deliver MS, the national study comparing early highly effective treatment to an escalation treatment approach. But the key thing is for people with active disease, with 2 relapses in the last 12 or 24 months, this is this is a population who you feel extremely anxious about leaving off DMT for any prolonged length of time. And I think the key thing is that we have to work as a team and meet them on more than one occasion and give them time to adjust to the psychological effect of giving the diagnosis, but still not lose track of them and let them drift off and then worry about our service pressures and realize 6, 9, 12 months later that we never got back in touch to explore whether they'd come round to the idea of treatment, whether they'd like any more information from us. So I think we need to keep track of our patients during this tricky time.
But it's a bit difficult. Terri, have you come across people that they say, actually, leave me alone, I'm not going to have any treatment for now?
Not the new diagnosis, no. I think people that are previously due for instance, their Ocrevus infusion, they've put that back to later on in the year when, we may be out of this second wave, we don't know. But some people are delaying, but I've not come across that many. But like Chris says, I think it's something we really need to follow up our patients and have, if they decide not to have a DMT, let's not get them lost in the system. That's something we're trying to be, improve and follow up in our nurse-led clinics, and just to have that conversation, just to make sure we're always here and provide contact details if they ever do change their mind.
And so what about the ABN guidance that suggests that our patients should either shielding or something as close to shielding as possible for 3 months after cladribine and alemtuzumab courses, and for a year after hematopoietic stem cell?
I think the ABN guidelines, and we know that at the moment there are lots of wise women and men are scratching their heads and they're looking at the data, they're looking at the evidence. It's very likely that we'll mellow the guidelines, because I think conservative Brits, correctly, I think they were very, very cautious in the beginning. The danger, of not giving effective medication, exactly as you pointed, Chris, is even more dangerous than sometimes the risk of the infection. We're getting lots of, and it's an exciting time, and one of the things that Afagh is getting excited recently. Let me share, one more screen. We're very lucky in the UK of having some national data, and these are the data that are unclean, are not, we haven't fully validated. And so, you could say, why are you presenting some data if you haven't validated? Because they're so powerful and some useful. So this is the blue tech. Every patient in the UK that goes on disease modifying therapy, they have to have their blue tech filled in and merged with the PCR data for COVID. And one of the things that you could see, probably, let's look at the data. Alemtuzumab, we had 245 people have been tested negative, 8 people have been tested positive. None of them have died, after a positive test. In total, we had 1,000 people and 100,000, 1,100 people with on alemtuzumab, and less than 1%, 0.72% of those on treatment have been tested positive. And we can look and say, okay, which is the numbers that appear to be high? Alemtuzumab seems to be higher than the rest. Then we go to this one, which is natalizumab. But also at the same time, we can see that natalizumab has a higher percentage of people being tested. So it raises the question, is it that people with natalizumab, that they come to the hospital to have their infusion, they're being tested? This we need to look into that. Which other medicine, then you can go into, 0.48, ocrelizumab seems to be the next, and fumarate, 0.5% of the people that they are on treatment have been tested positive. And on the deaths, you can see that most of the deaths come from people that they were on interferon. And we know that, lots of people with secondary progressive MS, they will still be on interferon. I don't want to expand on too much on this data. And let's see if I can stop sharing my screen now. But I think we are lucky that we have had the studies that Afagh has described, very well but also we are having national data because all our medicines are being prescribed, and we need to analyze that a bit more. Terri, what do you think? Oh, so Chris.
Well, I was going to say, can we jump in with one question from Monica Fenn? If we have time, we'll also fit in Dr. Hosseini's question as well. So, so Monica says, given the finding that poor mental health is a significant risk factor and more likely with our patients with primary and secondary progressive MS, should we be providing increased psychological or counselling support services rather than via a charity? So,
Monica, say that again.
Long-term problems if they are more likely to get long COVID and the second wave. So should we be lobbying or putting in place more services now rather than after the fact? Should we need change in response to this research?
You know, Monica, I'm with you. I'm with you. I think we have a lovely neuropsychologist here who looks after, I don't know, a few thousand people with multiple sclerosis and a few other thousand people with neurological conditions. And what can he do? So we rely on you know, charitable organizations that they might not be able to, you know, there is a bit of a community support now for psychological support, but Terri knows more about this than I do.
Yeah, it's something certainly we know, sadly, there is a huge waiting list for those that are accessing cancer, I think up to 8 weeks. And that's quite hard for those patients that want to access that service quite quickly. Obviously, there is escalation policies, you know, the crisis team if things are quite extreme in someone's mental health, but we are seeming to utilise more local counselling services where that patient lives and making that more accessible for the patient. Patients can either self-refer or we can refer on their behalf, but it's something we as a team are more aware of.
We are running out of time, as always. The Nottingham team is very, very talkative. Afagh, is there one thing that has impressed you recently? One final comment.
Many things have impressed me. So I'm actually relieved, as you said, it was pointed out, having MS per se doesn't seem to put you at an increased risk of COVID-19. I think the discussion we need to focus more on is that long-term rehabilitation for those who have had COVID and the impacts of the pandemic on the mental health of people with MS.
Fantastic. Chris?
No, I think that's it. I think those tricky discussions I have with our newly diagnosed patients, I think this will give me the reassurance to really push our view that patients who need to be on treatment, even in this pandemic, while there might be a change in the ordering that we would usually recommend, we should really be encouraging them and pushing back against the general anxiety that's out there in the community more generally around COVID. And stress the relative merits of the treatments we're offering.
And Terri, thanks, Chris. Any wise words from Terri?
Yeah, like just Chris said, I think we need to, you know, especially on new diagnosis, a team approach, making sure, you know, a nurse is there to give that patient that journey and try and reduce their anxieties and discuss DMTs and all their questions.
I think with this, I'd like to thank the MS Academy. I'd like to thank the participants. That, you know, I will also voice with Monica. We need to work a bit to get some more psychological support for people that are struggling. Have a lovely afternoon. Back to your clinics, back to your clinical work. Bye-bye.